Hi, I'm Dennis Nash, and today's session is on the emergence and spread of West Nile virus in the United States. Okay, so let's wrap up the outbreak exercise number 2, the Washington County Fair outbreak. You should have had an epi curve that looks like this, that shows the cases of diarrheal disease by date of onset after the Washington County Fair, and if you've annotated your curve, you would see that in relation to when the fair started, when there were heavy rains, and when the fair ended, and the cases that subsequently occurred. And in this epi curve, the investigators did stratify and shade the curve according to the degree of suspicion, whether they were a suspect case or a case that was confirmed by culture. You can get a sense here clearly that the epi curves of each of these different class categories in the case definition really mirrored each other pretty well. So you remember that well number 6 served the food vendors at the fair, and that nearby was a dormitory and a cattle barn. And in the case control study that the investigators did, they did find that well number 6 was associated with did have a very high odds ratio associated with being a case. In fact, 81% of the cases had some documented exposure to well number 6, making it a likely culprit. So the question really becomes, how did the water in well number 6 become contaminated? And so as part of an environmental investigation that complemented the epidemiological investigation, trying to understand the source of contamination, the investigators flushed. Well, first they isolated E. coli from different places in the well, in the pipeline to the well, and at where the water would come out of the well. All 3 places there was E. coli isolated, which suggests that the well water itself was contaminated. And in fact, they also did some sort of analyses of laboratory isolates, pulse gel electrophoresis, that showed, compared the characteristics of the isolates from the well with those of the ill patients, and found that they matched very, very closely to one another, suggesting that the well water indeed was the source of infection for the outbreak. They noted too that the well was about 36 feet from a seepage pit that was related to the septic tank that served this dormitory where some of the fair workers had been staying. And so they did an environmental investigation where they flushed different kinds of dye down drains from the dormitory and from the cattle barn, which had a manure storage area, which could have been a source of bacteria of E. coli as well that could have contaminated the well. And while this is not definitive, it was certainly suggestive. The green dye that they flushed down the dormitory was found in well 6, but the red dye that they flushed from the cattle barn area did not make its way into well 6, suggesting that the dormitory was the source of the contamination of well number 6. So the investigators concluded first that this was one of the largest outbreaks of E. coli 0157H7 in the US, and based on their household survey, they estimated that up to 5,000 fair attendees may have become ill as a result, and as we know, some very severely ill and hospitalized and worse. The source was an unchlorinated shallow well that was not regulated as a public water supply, because these temporary water supplies that are part of county fairs are not, at least were not at that time, regulated and monitored as public water supplies. So they recommended, to prevent similar outbreaks from occurring in the future, that they change these regulations, and New York State issued summary orders to prohibit the use of untreated water at agricultural fairs and require daily testing and disinfection of water supplies during these public events as a means of protecting the public and preventing these kinds of outbreaks going forward. However, it was noted by the investigators at the time that infrequently used water supplies are not regulated as much in other states around the country as they are now in New York. So that wraps up the waterborne disease outbreak example. And, having gone through the foodborne and now the waterborne, hopefully you're getting a sense of some of the common approaches that we're taking, that are taken in investigating outbreaks, but also some of the added twists and nuances that can come into play when the source or the causes of the outbreak are different. And so we're going to move now into the example of a vector-borne disease outbreak. And this is the outbreak investigation that documents the emergence and spread of West Nile virus in the United States. So West Nile virus is a flavivirus first isolated in the West Nile district of Uganda in 1937. It is endemic to Africa, Asia, the Middle East, and Europe, and now the Western Hemisphere as well. The maintenance and amplification cycle occurs between birds and Culex mosquitoes. Human infections are sort of incidental. They result from the bite of an infected mosquito, which is usually a Culex or other species. The incubation period for West Nile virus ranges from 5 to 15 days. Most of what's known about the clinical and presentation of West Nile illness comes from outbreak investigations, in fact. The majority of infections are asymptomatic or result in mild illness known as West Nile fever. West Nile fever is a self-limited dengue-like illness characterized by fever, headache, rash, lymphadenopathy, nausea, and vomiting. In rare instances of infection, West Nile can affect other organ systems. So a small fraction, less than 1% of West Nile virus infections result in severe neurologic illness, including a small fraction, less than 1% of West Nile virus infections result in severe neurologic illness, including meningitis and encephalitis. And these have a case fatality rate on the order of 10 to 15%. And severe neurologic illness is more likely to occur among elderly persons in West Nile virus infection. And this severe neurologic illness represents really the tip of the iceberg of West Nile infection. For every instance of West Nile central nervous system disease or CNS disease, there's an estimated 150 infections without CNS involvement. Again, most of these are asymptomatic, with about 20% resulting in West Nile fever or dengue-like illness. Over the course of this presentation, I'll try to give you guys a sense of where these iceberg estimates come from and how epidemiologists have derived them. This slide shows the geographic range of West Nile virus prior to 1999, when its spread was confined to Europe, Africa, and parts of Asia. However, in 1999, West Nile virus crossed continents and emerged in the Western Hemisphere, causing an outbreak of encephalitis in the New York City area, such that its current geographic range now includes most of the US and other parts of North America. The emergence of West Nile in 1999 was really an unprecedented event from which the public health, scientific, and veterinary and medical communities really learned a lot about emerging infectious diseases, public health preparedness, and cross-collaboration and communication. So for this talk, I'm going to cover in detail the events and knowledge gained from the emergence of West Nile in the New York City area in 1999 from an epidemiological standpoint, including the detection of the outbreak, the extent of West Nile infection in the community, and post-infection sequelae. So the latter part of the talk, I'll cover the subsequent spread and current epidemiology of West Nile virus infection in the US after 1999. So I hope that by the end of the talk, you'll get a sense of some of the current issues and the broader significance around the emergence and spread of West Nile in the US. It really represents a great example of an emerging infectious disease and its detection, and also a great opportunity to teach infectious disease epidemiology as well. So as we go through the talk about the emergence of West Nile virus, I wanted you guys to just revisit quickly these steps of an outbreak investigation that we that we talked about over the last few weeks, and keep them in the back of your mind as we're going through the talk. I'm not going to cover and mention each one as we go, but I think by now it's going to be possible for you guys to see the different things that we talked about in this list and how they played out in this specific example of West Nile virus in New York City in 1999. So it was in late August of 1999 that an infectious disease physician from Flushing, Queens, called the New York City Health Department about 2 encephalitis cases that she had seen at a hospital there. And both of the cases had encephalitis, but also an unusual finding with encephalitis of profound muscle weakness. And this is the reason why she called the health department. You recall that providers are expected to get in touch with the health department in situations where there's unusual clusters of illness. And she felt this was unusual enough to pick up the phone and call. And subsequently, the health department initiated an epidemiological investigation at that hospital and nearby hospitals that included medical chart reviews and interviews. And this uncovered an additional 6 encephalitis cases that were occurring around the same time and in the same community in northern Queens, bringing the total to 8. And this encephalitis cluster was comprised of relatively healthy individuals prior to their coming down with encephalitis, healthy between the ages of 58 and 87. They all presented with fever followed by altered mental status. 7 of the 8 patients had this unusual finding of profound muscle weakness, some with flaccid paralysis and EMG findings that were indicative of axonal neuropathy. Ventilatory support was also necessary in most of these cases, and based on some routine collection of cerebral spinal fluid, or CSF fluid, the testing suggested that the cause was probably a viral infection. So to assess the true extent of the outbreak, the New York City Department of Health immediately began active case finding and requested that all providers report similar cases. And also specimens were sent to the New York State lab, New York State Health Department Wadsworth lab, and the CDC in Atlanta. So this slide shows the temporal trends. Just to give you an idea, encephalitis and meningitis are reportable in New York City, and it's tracked through passive provider reporting. And over the 10-year period leading up to 1999, there was a median of about 9 cases reported in the city every year, and about 172 cases of meningitis reported every year. And most of these did not have a specific cause identified. Maybe they knew it was a viral infection, but not necessarily which virus. And to give you a sense of the trends here, there was a clear seasonal pattern that exists, particularly for meningitis, shown in green here, with peaks representing the enterovirus season. But to have 8 encephalitis cases occurring almost simultaneously in a highly localized area of the city was indeed unusual and required immediate investigation, and it probably represents an outbreak. This is more than what would be expected based on surveillance data. So just to jump into a timeline here, it was August 29th where this epidemiological investigation began, and when specimens were sent to the New York State Department of Health Wadsworth Lab and CDC for further testing. And this map shows the area of Queens, northern Queens here, and then sort of blown up on the right. The map on the right shows the significant residential or geographic clustering of these 8 patients, most of whom really lived no more than a mile or 2 from each other. And in the absence of an etiologic diagnosis and known cause of the outbreak, we needed to turn to epidemiology for clues. And so interviews with patients and families revealed actually no clear epidemiological links, like attendance at a common social event or a church supper or a restaurant. None of the patients reported having any contact with young children, and they had little social contact outside of the home. Importantly, no other household members were ill, making this person-to-person transmission less likely. But all the patients were noted to spend a lot of time outdoors around their homes in the evenings, engaging in activities like gardening. This area of Queens is a very residential area and very, lush and green at that time of year. And so in addition, investigation by an entomologist revealed that there were mosquito breeding sites and evidence of larvae in the patients' yards and neighborhoods. This was part of the investigation that included an environmental investigation in addition to talking to patients. So based on these findings, an arthropod-borne virus, or an arbovirus, was suspected as the cause of this encephalitis cluster. And so accordingly, the New York City Department of Health recommended that the testing of the specimens sent to the State Health Department and the CDC be tested for arboviruses. One thing of note at this point is that it would be unusual to have an arboviral infection or a mosquito-borne viral infection circulated in New York City, since there really hadn't been any cases of viral mosquito-borne illness in New York City since the early 1900s with yellow fever. So one question was, could this be St. Louis encephalitis virus, another mosquito-borne virus? It does occur in New York State, but not in New York City. But it seems reasonable to think that this could be a situation where St. Louis encephalitis was being spread by mosquitoes inside the city. The other thing of note here is that prior to the outbreak of encephalitis and during the outbreak, large numbers of crows were noted to die off in Queens and elsewhere around New York City. But there was really no direct connection to the outbreak in humans. It was just sort of a coincidental observation at the time. So naturally, the health department wanted to look for more cases and to understand the extent to which there was any more cases around the city. The goals of this part of the surveillance are really to identify the cause of the cluster, the cause of the outbreak, and also to define the magnitude and geography of the outbreak. To identify the cause of the outbreak, it really comes down to trying to confirm the extent to which all of the cases in that initial cluster of 8 and any subsequent clusters or subsequent cases are related to one another and not, different causes, different etiologies. And also to get clues regarding the potential source of the outbreak. And this was why there was added testing recommended here. More testing could potentially identify the actual cause, the actual virus that was causing the cases of encephalitis and meningitis. So the state and the CDC both have the ability to do more extensive testing than standard testing available in hospitals and commercial labs. And it's also important, since these are non-standard tests, for epidemiologists to work closely with laboratories and laboratorians to ensure that the specimens that they need, which are not routine necessarily, are collected, stored, and shipped properly so that they can be tested as quickly as possible with results turned around as quickly as possible. So to define the magnitude and geography of the outbreak, we're wanting to try to understand things like how long was this outbreak going on prior to recognition. We've talked about how the first cases that come to the attention of epidemiologists and clinicians in outbreaks aren't necessarily the first cases that occurred in the outbreak. So the index cases are the ones that we first learn of, but it could be that the outbreak was happening and the first cases occurred, well before the cases that were first recognized. And also wanting to understand what is the extent of the outbreak. Is it limited to northern Queens? Is it spreading across a larger geographic area? And also, what are some of the risk factors for infection and disease? So to try to expand surveillance and begin to learn about whether or not there were more cases, the health department needed to alert providers and ask them to report certain cases that they may be seeing. And to do that, it's really important to have a case definition, as we've discussed many times. And the health department at this point turned to the observations about their initial cluster of 8 people to help put together a reasonable case definition that could be useful to look for more cases. And so we started with the clinical syndrome of the initial cluster of 8, which all had fever, altered mental status, abnormal cerebral spinal fluid, test results with suggestive of viral infection, and also this finding of muscle weakness. So providers were asked to report anyone who met met those criteria, or presumed viral encephalitis, or fever with presumed Guillain-Barré syndrome or acute flaccid paralysis, and also presumptive aseptic meningitis, which means viral meningitis. And then we had a case definition that had a degree of suspicion. So if these were all 4 of the criteria, they would be considered probable cases if all 4 criteria were met, or suspect if 3 of the 4 criteria were met, and low probable if 2 of the 4 criteria were met. This also helped us triage what were limited resources available for testing in the early phases of the outbreak. So what did the surveillance and case finding, expanded case finding, look like? The health department used methods including like faxed alerts to healthcare providers and hospitals to remind them or to alert them of the need to report cases that they might see that are consistent with the symptoms and other findings outlined in that case definition. They would make weekly calls to all the city hospitals to learn about new potential cases. And then all the cases so that was the active part of surveillance. And then they would prioritize all these potential cases that they learn about for rapid specimen collection, and those specimens would be shipped as quickly as possible to CDC and the New York State Health Department for testing. There would also be daily status checks with infectious disease services at hospitals around the city of the critically ill patients, and alert the physicians and the medical examiners about the need for autopsy of those patients to get some of the tissue specimens that would be needed to do more diagnostic testing. And finally, it was important to get not just an initial specimen, but also convalescent specimens further out after the development of symptoms. So because those earlier specimens might be negative since they're early in the course of infection, and these were antibody tests. And so for those patients where the initial specimen was negative, we wanted to get a subsequent specimen just to make sure that we weren't missing a positive case that we would test for antibodies later on. So all this work was going on to find new cases and potential cases that were associated with the outbreak, and get specimens that we could then send off to the state and CDC for testing. And in the process of this case finding, a preliminary positive immunofluorescent assay positive came back from the state for St. Louis encephalitis. That was on September 2nd. So this was very soon after the initial investigation was begun, to give you a sense of the timing. And by September 3rd, CDC had reported through a more specific test that the IgM ELISA for St. Louis encephalitis was positive in some of the specimens that were sent there. And so that allowed us to begin to modify the case definition, because this suggested that the outbreak was being caused by St. Louis encephalitis, confirming the suspicion of mosquito-borne illness. And so the case definition could now include a confirmed category that added the lab test, the laboratory testing criteria. With this information really represented confirmation that there was a mosquito-borne viral encephalitis outbreak actively happening in the confines of New York City. Mosquito control was begun right away in northern Queens and the Bronx, and this created a big stir. First, just the identification of a mosquito-borne viral outbreak in New York City was big news, and also a lot of attention to the response of spraying pesticide around the city really caused a media frenzy. And I like this slide in particular for a couple of reasons. The first is that the journalist at Newsday, while this outbreak was happening, was Laurie Garrett, who is the famous author of Infectious Disease Epidemiology, or Infectious Disease books like The Coming Plague. And she was writing some of the stories about the West Nile outbreak as it was happening for Newsday. But also it has this sort of definition that we've talked about of an outbreak, which is, more than what you would expect, built into the headline here. Outbreak, encephalitis, rare in city, kills at least one, infects dozens in Queens. So even before we knew that West Nile was the ultimate etiological agent, since transmission was linked to mosquitoes, a massive adult mosquito control campaign was begun in northern Queens, and eventually the entire city was sprayed with pesticide. The response, the public health response, was comprehensive and really unprecedented. As far as outbreak responses go at that time, it required coordination across the local, state, and federal jurisdictions. And it included not just surveillance for human cases, but also doing surveillance for mosquitoes and trying to control the mosquito population, including pesticides, but also larvicides to eliminate mosquito breeding sites, or to eliminate the larvae that could be breeding mosquitoes, and distributing mosquito repellent to the general population so that they could protect themselves as well. Lots of public health education, including public service announcements and neighborhood canvassing. We set up a hotline that was staffed 24/7 and received many, many calls over the course of weeks and months. Lots of communication and coordination with the media, lots of physician education, including health alerts, and ongoing citywide surveillance for additional cases through the end of mosquito season, which officially ends when the first frost happens. So this slide shows a spot map of eastern New Jersey and New York City and southern Connecticut and western Long Island. Northern Queens was clearly an epicenter for this outbreak, and no human cases were detected outside of New York State early on. In addition to the surveillance for West Nile cases of meningitis and encephalitis among humans, surveillance was also being carried out in the bird and mosquito populations. So this map shows the map of the human cases, and on September 8th, after mosquito control had really begun in northern Queens and the Bronx, we learned of a confirmed case in Brooklyn that was really 12 miles from the larger cluster in northern Queens and the South Bronx, which indicated that spread was happening in a wider geographic area than had originally been appreciated. And this prompted the city to expand mosquito control efforts outside of that initial geographic area where the cluster was found to go full on spraying citywide. This is someone you may recognize, Mayor Giuliani at the time, and the media thought that he was really in his element, managing a citywide crisis and really stepping in to begin to respond, to lead the emergency response to this crisis, epidemic crisis. Just to return to this notion I mentioned earlier, this situation of the bird deaths that were noted to occur around New York City, not necessarily linked to the outbreak, but certainly coincident in time and in space. Some deaths were noted before and also during the human outbreak of encephalitis. Initially, when we mentioned this issue to the folks at CDC Atlanta who were helping with the testing and helped make the diagnosis of St. Louis encephalitis in our specimens, we were told that the birds really had nothing to do with the human outbreak, because even though that birds in St. Louis encephalitis, birds are the reservoir for the viral infection, but if the virus killed the birds, it would really be hard for them to serve as the reservoir for the virus. So that made no sense to the team at CDC, and we were pretty much instructed to ignore it from their perspective. However, other people outside of the city health department and CDC were doing sort of their own investigation. This is showing some veterinary pathologists who were examining the dead bird clusters in similar ways that we were examining the human clusters of disease. And this is what ultimately led to the discovery that, in fact, the outbreak was not caused by St. Louis encephalitis, but a closely related virus, West Nile virus. The large bird die-offs that were coincident with the human outbreak were found to be due to encephalitis as well in the birds. So these autopsies that veterinary pathologists were doing found the birds having similar symptoms to humans. A flavivirus, which is the class of virus of West Nile and St. Louis encephalitis, was isolated from dead birds found in Connecticut and New York. And ultimately, through a lot of testing, West Nile virus was identified as the common cause of both the human and the bird encephalitis outbreaks. And this was also quite a big deal in the news media. So this is a headline saying here, second virus, potentially deadly West Nile encephalitis is detected in birds in the city. So what was the reason for the delay in the identification of West Nile virus as the true cause of this outbreak? Well, partly it was because there is cross-reactivity among the flaviviruses. So the antibody tests for St. Louis encephalitis would also find that people would also react to people infected with West Nile virus. So there's a cross-reactivity due to the similarity between the viruses. It was also hard to culture the virus from the human specimen, so there was really no way to observe and look at the virus directly. And as I mentioned, the bird die-off was really felt to be unrelated to the human outbreak because arboviruses normally don't kill their avian hosts. So this has led the public health community at the time not really to consider the fact that, those two outbreaks could be related. And what led to the recognition of West Nile virus as the cause of the bird deaths really was what made this connection happen in the end. It came as a result of other investigations that were happening at the Connecticut Agriculture Experiment Station, the National Veterinary Service Laboratory at USAMRIID, the New York State Department of Environmental Conservation, the Wildlife Conservation Society at the Bronx Zoo. They had flamingos that had died there, and a very astute veterinary pathologist who investigated them carefully and really was pushing the CDC to test those specimens as well to see if there was a link. And also the Emerging Diseases Laboratory at UC Irvine that was at the time led by Ian Lipkin, who is now at Columbia and has done a tremendous amount of work around emerging infectious diseases since then. So all of these things sort of came together to help identify the true cause of the human and bird related outbreaks as West Nile virus, which is a new emerging infection never before seen in the US. And so in 1999, the West Nile virus really crossed continents and emerged in the Western Hemisphere, causing an outbreak of encephalitis in the New York City area, such that its current geographic range now includes the US and other parts of North America. At this point, though, the outbreak is still ongoing and more cases are occurring. And as we've talked about in prior sessions, the goals of surveillance can change over the course of an outbreak. And we were focused very early on identifying the etiology and defining the magnitude and geography of the outbreak. But once those were identified, there were additional goals to understand the need for whether or not there might be the need for more mosquito control measures, either in areas that have not received spraying before because there hadn't been cases there. Are there cases occurring there now, and thus identifying a need for targeted intervention? Or even in the areas that were sprayed, are there new cases that are cropping up again? I mean, this kind of thing needs to be evaluated until the outbreak is over. And so the goals of surveillance at that point were really about trying to identify new cases and evaluate whether or not there's a need for additional mosquito control measures than what are already happening. So eventually we moved on to the point of the outbreak where we were disseminating our findings. Actually, before this, there were many MMWRs that were released to update the public health community about what was happening with regard to the outbreak. Ultimately, we published a very sort of comprehensive paper in the New England Journal about this outbreak in 2001. And here you can see our epi curve, hopefully developed along the lines of how we describe them and how they should be constructed in class. But here you can see from the title here that this outbreak ultimately had 59 cases of West Nile virus that were hospitalized in the New York City area in 1999. You can get a sense of the trend, the uptake, the tick in cases going back as early as the first week of August. Remember, the outbreak really wasn't detected until this last week of August, very late in August, around August 29th, so around the time when the outbreak was peaking. We, through all the case finding, we actually identified 713 cases that met one criteria or another of the case definition that I described. And through the laboratory testing, we were able to confirm 59 of these as West Nile virus cases. And of those 59, there were 7 deaths for a case fatality rate of about 12%. And this slide is showing a map at the end of the day, a spot map of all of the cases that had occurred. You can see that we had many more cases in the Bronx and Queens, and also more cases in southern Brooklyn, and 1 case in Manhattan. Initially, we were very concerned about the idea of spraying citywide after just hearing about that 1 case in southern Brooklyn. The choice was maybe we should just spray in southern Brooklyn in addition to Queens and Bronx. But the mayor was pretty strong, had a very strong position and wanted to spray the entire city. Later on, we did learn about a case of an elderly woman who lived on Central Park South, and she would really only leave her apartment once a day to go sit on a park bench right at Central Park South and never really traveled anywhere else. So after investigating that case, we felt pretty confident that the infection that she had acquired happened in Manhattan near Central Park South. And so the decision early on by the mayor to spray the whole city was probably the right one. But this map is showing the geographic distribution of the positive human cases. I mentioned there was also surveillance going on in birds, and they were doing seroprevalence surveys in bird populations around the city. And these circles represent the proportion of birds that had a specimen that were positive for West Nile virus. So you can see that the positivity rate, for the most part, correlates with the number of human cases that we're seeing. And I also mentioned that there were surveillance in mosquitoes. There were mosquito traps that were set in different places around the city by CDC that would trap mosquitoes, and then each day they would be gathered and tested for the presence of West Nile virus in mosquito pools. And the green dots show places where there were positive mosquito pools, were positive for West Nile virus. Notably, they were also doing some capturing of mosquitoes in New Jersey. There were 2 positive mosquito pools, but not any positive human cases. And we thought that it's probably not that there weren't human cases happening in New Jersey, but they weren't really doing much in the way of active surveillance for cases. So it's one of those things where if you're not looking, you may not find it. There was some genetic sequencing of the different West Nile isolates that could be gathered from humans, birds, and mosquitoes in the New York area, and they all showed more than 99% similarity to a strain of West Nile virus that was circulating in an outbreak in Israel in 1998. And so this was thought of as the likely origin of the virus and where it was before it came to New York City in 1999. In our manuscript, in our outbreak paper in the New England Journal, we described the characteristics of the patients by age, by sex and race and ethnicity, and by geography. Here you can see the number of patients, but we also brought in information on the denominators so that we could calculate rates of infection, which are shown here. The rate of infection, really the rate of severe West Nile infection, because we're looking at hospitalized cases per million population. And you can see the very rapid increased risk with age, such that people aged 80 and over were 50 times more likely to be hospitalized with West Nile virus in New York City compared to people aged 0 to 19 years. So a very strong age gradient. Also, male sex was associated with a slightly higher risk, as was being white compared with non-white. And this was probably mainly because of the location of the outbreak in that sort of residential area of Flushing, Queens, or northern Queens. And then also, again, shown here, you can see how Queens, among the different areas of New York, the Bronx and especially Queens were most severely affected, but also some higher rates outside the city in nearby counties, Nassau and Westchester. And this is just a graphical representation of the age gradient I mentioned. It really wasn't until age 50 that we begin to see rapid increases in the risk of hospitalization with West Nile, according to age, older age. So this is just describing some of the clinical characteristics of the cases, of the 59 cases. The majority had encephalitis, about 29% had meningitis without encephalitis, and 8% had fever with headache. The most common documented signs and symptoms were fever and weakness, nausea, vomiting, headache, and altered mental status. And also the prevalence of comorbidities was also high in some instances among these hospitalized cases. The numbers in the number of people, 59 in the case group, was pretty small, but we did want to do some analyses to see if we could understand what factors might be associated with some of the outcomes, more severe outcomes, including death. And what we found was that having diabetes and having older age were most strongly associated and independently associated with the risk of death in severe West Nile infection. Sort of moving into the realm of lessons learned through the outbreak. This one is about the power of physician reporting. As I tried to describe in the timeline, the first cases were reported by the infectious disease physician at Flushing Hospital in Queens on around August 28th or 29th. But after we did the full outbreak investigation, we found that there were cases happening, well before that. These were just the first ones we had heard about. And showing here, we could look back and identify the cases that were actually reported to the health department through physician reporting. So 2 of these highlighted ones were reported by the clinician at Flushing Hospital to the health department. These 2 others may have been reported by another provider, but all these cases that were identified in the outbreak in orange were never reported to the health department. And the lesson here is how important it is for physicians to report. It's quite possible that if that physician hadn't called the health department, the outbreak may not have been recognized for even longer, or maybe not even recognized at all. And so for this reason, the health department really prioritizes developing good relationships with physicians so that they understand the value of provider reporting of cases to the health department. Another important lesson learned here was looking at the sort of yield of surveillance. We were doing surveillance for, as you saw with our case definition, encephalitis and meningitis, really of any age. And this slide just shows like what the positivity rate or the yield was for different components of the case definition. And you can see that encephalitis with weakness was the most predictive of being associated with the outbreak and having, West Nile virus infection. Also, any encephalitis. Meningitis was less predictive, but still 16% were positive. And then also looking by age here, younger people that met the case definition were much less likely to be positive than older people. And so this is a refinement that could be made to the case definition going forward, which is to really only consider older individuals with encephalitis and meningitis as potential West Nile cases. You can eliminate a lot of extra work by really just focusing on the older population. Of course, other lessons learned include the importance of having strong relationships with the medical community, or between the medical community and public health. That relationship between the physician in Northern Queens and the health department, that she knew that it would be important to pick up the phone and call the health department to let them know that something unusual was happening, really made a huge difference in detecting this outbreak quickly. Also, lots of lessons learned around the need to remain open-minded to the possibility of the unexpected. So this idea that, of not considering that a bird outbreak could be connected to a human outbreak, when we know that emerging infections are becoming more and more common in this day and age, really emphasizes the need to remain more open-minded about the different things that could be going on. This outbreak also really highlighted how important it is for public health to partner closely with people that we weren't always used to partnering with, like veterinarians and ornithologists and veterinary pathologists who were doing their own investigation independent of the public health and epidemiologic investigation. But that really shouldn't happen. When there's a possibility that these things are related, there really should be close partnering between the two, and including testing specimens from humans and animal populations. And also the importance of monitoring unusual events in animals and birds as harbingers of human disease outbreaks. The old adage is, when you hear hoof prints or hoofbeats, think horses, not zebras, because horses are probably the most common, the most likely cause. But I think what we take away from West Nile, and also the many other emerging infections that we're seeing increasingly, is that you need to think about horses and zebras. The emergence of West Nile in 1999 really was so unprecedented that it became important to do a number of other investigations that maybe normally wouldn't happen, but because it did represent an emergence of a new virus in the Western Hemisphere, we also decided to do a household serosurvey in Northern Queens to really sort of understand the extent to which the virus spread within the community there. And so this was a household survey that also got a lot of media attention because it was so unprecedented. The health department was going door to door in Queens to get blood specimens from residents so that we could track this encephalitis outbreak that was happening. Our teams were deployed in Northern Queens and going door to door. And this was, I think, a great slide where one of our team members sort of turned the tables on the media and took their picture instead. But you can get a sense of what it was like at the time for our teams in the field to be going door to door. They were really followed by several journalists and media types trying to just document and describe what was happening. We chose to conduct this survey in Northern Queens because it was the area with the highest attack rate of clinical West Nile infection in the city. We mapped the number of cases according to the population, and you can see where the highest rates were. So this was a household survey that was with specimen collection for serology that was conducted in a 2x2 area of Northern Queens. The participation in the household survey was about 44%. And we conducted interviews and blood specimen collection among people aged 5 and older. And there were 677 respondents to the survey. And in the population in this 2x2 mile area, there were about 47,000 residents there. And we compared the characteristics of our sample to those according to the census. And you could see that for the most part, they were pretty well aligned with each other. Our survey sample was not that different from the population estimates from the census in 1990. Overall, the estimate of the seroprevalence was 2.6%, and it was relatively similar in each age group, which this notion of similar in each age group is consistent with the introduction of an infectious disease into an immunologically naive population. If we had seen a very strong age gradient such that older people were more likely to be infected than younger people, that would suggest that this is something that's been around for a long time and it just hasn't had a chance to infect the younger people yet. But this kind of curve where there's really no difference in the rates by age suggests that this is a novel virus that had just arrived in New York City. We looked at some of these are some of the household characteristics and some of the questions we asked people about knowledge and behaviors. Of course, the city was doing lots of public service announcements, lots of health education, trying to get people to understand all the things that they could do to protect themselves from mosquito bites. And so we assessed the level of knowledge and behaviors that people were engaging in when we did this survey to get a sense of how well these education campaigns were working. And we also looked at the extent to which some of these things were associated with seroprevalence. I mentioned 2.6% positive in the entire survey, but if you looked at different groups, such as those that spent more than 2 hours outdoors after dusk or before dawn, when these particular mosquitoes that spread West Nile were out, the prevalence was higher. If they did not use mosquito repellent, their prevalence was also very high, and if they did use mosquito repellent, it was lower. And also this notion of whether they saw any dead birds in their neighborhood. If they did report seeing dead birds, they were more likely to be positive. So this notion that dead birds as a harbinger for an outbreak or a marker for spread of the virus is pretty substantial. So this is the West Nile human infection iceberg that I showed you before. So I'll just try to give you a sense of where these estimates came from, right? So we have about, a very small proportion of people who are infected have central nervous system disease. Only about 20% of people have any kind of symptoms, and those are usually mild when they occur. And the vast majority of people don't have any symptoms. So what were we able to say about this in our outbreak investigation? Well, we could see that there were about 19 people, or 2.6% of our sample, who were seropositive that participated in our survey. We also asked people about their symptoms, and about 21% of those seropositives actually had reported that they had a recent history of fever. And these were some of the symptoms that they reported. And they were all consistent with this West Nile fever picture. We had 44 cases of West Nile virus that had neuroinvasive disease, and extrapolating, using some of the estimates from the literature, we would say that there were about 1,700 people with West Nile virus that had fever, and then about 8,200 cases total. And with this estimate, we came up with something very consistent with what has been reported in the literature of about one hospitalized case for every 186 infections. So for about each hospitalized case, there were about 30 additional cases of milder or West Nile fever cases. So we get these estimates up at the top from disease surveillance, the number of severe cases, and we got these estimates from the proportion of people with West Nile fever and asymptomatic infection from the seroprevalence survey. So this gives you an idea of how some of that information from an outbreak investigation and a seroprevalence survey can come together to give you a sense of the spectrum of disease in the case of West Nile. So We've covered the outbreak investigation. We've covered the seroprevalence survey. It was also important to do a little bit more in the way of investigation to understand what happens among people who survive West Nile infection. So I mentioned there were 59 cases and 7 deaths, but that leaves a fair number of people who survived West Nile infection, severe West Nile infection, and there wasn't much in the literature about this, and we thought it was important to begin to characterize what happened to these survivors and what their recovery was like beyond that acute illness phase. And so we conducted a follow-up study in the surviving New York City West Nile patients. The goals of this study were to describe the recovery experience and characterize their longitudinal antibody response and assess their health status at 12 months post-onset relative to their baseline prior to becoming ill with West Nile infection. So we started with 59 cases and 7 deaths, and we wanted to focus on who survived, and we focused on New York City residents. So we invited about 42 people to participate in this longitudinal follow-up study of recovery. The protocol included serologic testing at 6-month intervals until the person was no longer making IgM antibodies. We conducted telephone interviews at 6, 12, and 18 months, and we assessed recovery status at the 12-month interviews across 3 domains of health status: their physical health, their functional health, and their cognitive or mental health status. We had to assess, because we didn't really come into contact with these cases until after they became ill, we had to have them recall their baseline health status at the time of the 12-month interview. This gives you a sense of the kinds of things we asked about, the outcomes that we assessed in the phone interviews. These are the different specific components in each of these domains of physical, functional, and cognitive health. And we created scores in each of these domains, basically adding up the number of times that they reported some of these outcomes. And as a measure of their recovery, we looked at the ratio of the 12-month score to the baseline score. So a patient could have had a 12-month physical score that was 40% or 95% of their baseline score, right? And they were considered recovered in a given domain if their 12-month score was 85% or more of their baseline score. And persons were considered fully recovered if their 12-month score was 85% or more on all 3 domains. So we were able to, this gives you a sense of the participation. There were 42 people who were eligible. We were able to do a baseline interview on everyone as part of the outbreak investigation, but we only had serum on a much smaller number of those patients, and we only had a 12-month follow-up interview on 35 of the 42 patients, so 83% of the survivors. And this gives you a sense of the participants compared with the non-participants. We tended to lose people who were younger and had higher participation among people who were older. And this slide is showing the IgM levels of patients over time. And one of the surprising findings that we saw was that of the patients for whom we did IgM testing 500 days out, 60% were still making IgM antibodies, which is much longer than we thought they would persist. And as we would expect, the IgG neutralizing antibodies would become more common with time, and you can see the curve here over the course of time out to 12 months, but everyone for whom we had a specimen available was positive for IgG antibodies to West Nile virus. Looking at their recovery relative to baseline, which again was via recall, in all domains, the surviving West Nile patients reported lower scores compared to baseline. And when we calculated our estimates of recovery, you can see that in all domains, less than 60% of people had sort of recovered, physically, functionally, or cognitively. And when you ask the question like, well, how many recovered in all three domains, really it was much, much less. So only 37% of people, according to our definition, were considered fully recovered after having been hospitalized with West Nile infection a year later. It's not something that you get infected with, go into the hospital, and sort of leave and resume a normal life. These folks had very significant changes in their routine daily functioning and activities. We also wanted to see what we could find that might be predictive of their likelihood of recovering, even though so few did. And the strongest factor that we could find as potentially important here was younger age. So people who were younger were more likely to be recovered fully by 12 months. Of course, this was a small study and we were limited by the small sample size, and we had to rely on self-reported data to assess people's recovery, especially the baseline status, which there could be bias introduced through recall, and we couldn't really validate our recovery scales externally. But nonetheless, we feel like the study did shed a little bit of light on the fact that people weren't necessarily returning to normal life after leaving the hospital after West Nile. So that's the story of the emergence of West Nile virus in 1999 in New York City and everything that we learned from it in the process. But I also want to talk a little bit about what's happened with West Nile virus in the US after its introduction in 1999. There was a lot of discussion and debate about whether or not, after the cold weather came and mosquito season ended in 1999, whether or not West Nile virus would survive the winter and begin to spread again in subsequent years in New York City and elsewhere. It's quite possible that the virus wouldn't survive the winter. So it was a big open question about what would happen next, and if West Nile virus was here to stay or not. And I guess just to drive the point home and to say it in a nutshell, just like many things, if you can make it in New York, you can make it anywhere. Since 1999, this map shows the years in which West Nile virus began to spread across the US like a wave, basically, and by 2004, it had caused outbreaks in every US state. And there were much larger outbreaks than we experienced in 1999 as well. You can see here there were thousands of cases occurring of neuroinvasive disease, as well as deaths, case fatality rates that maybe were a little bit lower, but sometimes around the same of what we observed in 1999. And also in many instances, more, compared to St. Louis encephalitis, more deaths. And so it's even possible that West Nile virus was, having more epidemic potential in the United States than St. Louis encephalitis virus. This is kind of the average annual incidence of West Nile neuroinvasive disease over a period of about 20 years since the emergence in 1999, and you can see that tends to be higher incidence and transmission in certain areas of the country, in the South and in the Midwest regions of the US. This is sort of just graphically showing the trend since 1999 in the number of cases, the incidence rate per 100,000 population. So some years are more intense than others. But in every year, there have been a substantial number of cases, certainly many more than what we saw in 1999. And also, if you look at the equivalent of the epi curve, the epidemic curve, combining all years from 1999 to 2018, you can get a sense of the seasonal nature of the virus. And so cases tend to peak in late August, late summer, every year in the US, and not much transmission going on in the winter, if any. And ongoing surveillance for West Nile has sort of borne out the early trend we saw by age, with older people being significantly higher risk compared to younger people of neuroinvasive disease. There were also some new modalities of West Nile transmission that have been identified since it emerged in the US. The risk of West Nile infection from blood transfusion was identified and estimated to reach a peak of about 21 per 10,000 in 2002. And beginning in 2003, there was a newly developed nucleic acid amplification test that can be used and is used now to screen out blood donors who may be in the early stages of asymptomatic West Nile virus infection. So certainly the blood supply needed to be dealt with because it was a threat. But other modes of transmission, including breastfeeding, transplacental transmission, and cases of occupational exposure in laboratories. Since there's the need to screen the blood supply for West Nile, it also can be used as sort of a source of surveillance to identify areas where cases are being detected through screening, and when cases are being detected through screening of the blood supply. And you can get a sense of how that has played out here, for example, in 2004, where they were picking up cases of West Nile virus, active West Nile virus infection in the blood supply, or in the process of screening to protect the blood supply. So in summary, all these events and the epidemiological information gained following the emergence of West Nile virus in 1999, we can conclude that 1999 represented the first occurrence of West Nile virus in the Western Hemisphere. There are some unique features of the outbreak that led to its discovery, specifically the predominance of muscle weakness in those encephalitis cases in the initial cluster that resulted in a physician picking up the phone and calling the health department to let them know that something unusual was happening. There was also the unique feature of bird deaths early on, prior to and during the human outbreak. We learned that it primarily affects older adults in terms of its severity, and age and diabetes are the strongest predictors of death given a severe case of West Nile virus infection. In the outbreak investigation around the time of its emergence in New York City, we found a 2.6% seroprevalence in northern Queens, so a substantial proportion of the population was infected over a short period of time, and that about 1 in 186 infections resulted in neurological disease. And there is also a clear evidence of post-infection sequela and antibody response, with IgM antibodies persisting out to a year after infection in some cases, and maybe longer. And most patients we found with clinical West Nile virus infection did not fully recover by a year. In terms of the spread of West Nile virus since its introduction in 1999, it's clear that West Nile virus has become endemic in North America since it arrived. It spread rapidly westward in the years following the 1999 emergence. And it actually caused the largest documented arboviral outbreak in the Western Hemisphere. And it even may have greater epidemic potential than St. Louis encephalitis. There were some new modes of transmission identified in the process, and it was also shown that the world's largest documented West Nile virus outbreak with neurological disease occurred in North America in 2002. In terms of future West Nile virus activities and issues, it will likely continue to spread in the Americas, and the timing and the intensity, as we can see, it can be variable and somewhat difficult to predict, but there'll certainly be a need for ongoing surveillance and prevention of West Nile virus spread, and that would include surveillance in mosquitoes and also in the bird population and the human population. There's not really well-known or well-discovered treatments for West Nile virus disease yet. There are some that are used, but the efficacy is not really well characterized. And human vaccines, human trials for West Nile virus vaccines started in 2015, but there's not a vaccine for humans as of today. It's not clear when there may be. But this is sort of an example, sort of the concern about how sometimes it can take a very long time from when trials start for vaccines and when they actually find efficacious vaccines. So remember this list from prior lectures. West Nile virus shows up on this list of examples of emerging infectious diseases that we've covered in the course, and there have been many since. And for better or for worse, I think we've, again, a healthy fear of mosquitoes in North America now has returned, partly because of the emergence of West Nile virus in 1999 and beyond. So I don't want to wrap up the lecture without acknowledging a lot of the many teams and players involved in this work in New York City in 1999 and beyond to characterize West Nile virus, the emergence of West Nile virus in New York City, in the New York City area and in the Western Hemisphere. And also want to acknowledge our colleague, Deborah Asness, who was the physician from Flushing Hospital who called the health department and alerted us to the unusual cases of disease that were occurring there. Without that, we may not have even known that the West Nile virus outbreak had been underway.